Okay, I think we'll go now.
Yeah. Thanks, Julie.
Hello, everyone. Good evening, good afternoon. In a series on gender responsive budgeting and progressing breast. Our topic is gender responsive budgeting and the financing of maternity care in the Australian Federation. I'm Honorary Associate Professor Julie Smith from the National Centre for Epidemiology and Population Health at the Australian National University. My co-chair tonight is Naomi Hull, National Coordinator of the World Breastfeeding Trends Initiative Australia. Our program of webinars aims to galvanise efforts to improve breastfeeding policies and funding in Australia's government budgets using a gender budgeting perspective. We're pleased to be supported tonight by the Australian Centre for Federalism, the Crawford School of Public Policy, the ANU Gender Institute, World Breastfeeding Trends Initiative Australia, and the Breastfeeding Protection Network of India. Our webinars during the 2020 COVID-19 emergency focused on optimal infant and young child feeding in emergencies and the Australian National Breastfeeding Strategy. Tonight, we have expert speakers on the federal financial system and maternity care to bring a gender lens to influence the flow of health system resources for women during childbirth. Central to this in Australia is how the National Healthcare Funding Agreements direct resources to ensuring quality maternity care. We'll introduce our speakers in a moment. The Indigenous women of Australia have been birthing, breastfeeding and raising children successfully on this country for tens of thousands of years. Their skills and knowledge about childbirth and breastfeeding and safe complementary feeding of infants and young children has been key to their health and survival. The trauma experienced by Australian mothers who were wrongfully separated from their newborns during COVID-19 is something that many of our Indigenous women have experienced as ongoing for decades. It continues today. Like many women giving birth during the COVID-19 pandemic and in emergencies and disasters today everywhere, the experience of Indigenous women has been that the authorities have not enabled them, but have denied care, preventing them from breastfeeding their infants. We have much to learn about trauma and grief from Indigenous women and from their history of resistance and resilience over the past 200 years. I would like to acknowledge the Ngunnawal and Ngambri peoples who are the traditional custodians of the Canberra area on which this meeting is hosted, and I pay my respect to the elders past and present of all Australia's Indigenous peoples. During the COVID-19 emergency, the United Nations Human Rights Office stated that women and girls suffered egregious violations of their human rights, including restrictions on access to reproductive health care. Despite authoritative health guidance emphasising that breastfeeding should be protected, supported and encouraged, the human rights of women and children to breastfeeding were violated through the proliferation of maternity care barriers to breastfeeding. These breaches included the unnecessary separation of newborns from mothers' products for mothers and infants and young children, even through health channels. By WHO researchers early in 2021 that deaths among infants affected by policies of separation and non-breastfeeding would be at least 67 times greater than the mortality potentially attributable to COVID-19 among those infants. So this 2024 webinar will build on our earlier program to interrogate the ways in which Australia's federal system influences maternity services responses to crisis. It will focus on how our health financing arrangements and crisis management systems shaped management of maternity services and infant and young child feeding support during emergencies and disasters since 2020. In particular, with the gender budgeting lens, we'll ask where, how and by whom are decisions made on maternity care funding? Are we getting better value from the rising cost of maternity care? And is priority being given to implementing a key priority action in the Australian National Breastfeeding Strategy, the Baby Friendly Hospital Initiative, and the WHO UNICEF 10 Steps? My co-host, Naomi Hull.
Thanks, Julie. So along with our wonderful presenters that we have tonight, we've also had Diane Paul and Andini Pramano working hard behind the scenes to bring this webinar to you all. Could I just ask that you all have your audio switched to off during the presentations, and remember that we are recording this event, so you will be able to view it later if you do need to step out. All questions and comments will be considered and hopefully answered. There is a Q&A box down the bottom, so we prefer that you use that for any questions that you might have for the presenters, and we really hope that we'll have time towards the end to address those questions if we can't address them in the Q&A box. So as you would already know, we have many expert speakers to take us through the program tonight. Firstly, we'll have the Honourable Emma Hurst, a member of the New South Wales Legislative Council and chair of the inquiry into birth trauma, who will start with setting the scene with some opening remarks on birth and bonding, separation and grief. Then we will learn how funding moves through the federal finance system to maternity care from Charles Maskell-Knight, who is an expert in Australia's health financing system. Dr. Monica Costa will then give us an overview of gender responsive budgeting and how we might apply that to maternity care funding in Australia, followed by Associate Professor Carleen Gribble on what happened to maternity care protocols for breastfeeding support around the world during the COVID emergency. Dr. Andini Pramano on the costs and benefits of maintaining baby-friendly hospital standards of maternity care will follow. And then Professor Jenny Gamble is joining us from the UK on value and impact from funding arrangements in Australian maternity care. Alessandro Ilamo on the realities of funding priorities for maternity care and infant feeding support in emergencies and disasters. And then we are aiming to close at 8:10 after considering some questions and comments and closing remarks from Professor Miranda Stewart, who is an expert in taxation and fiscal policy. So there are brief biographies on the website that you access to register for tonight. So make sure you have a read of those there. And so now I'm going to ask the Honourable Emma Hurst MLC to take us forward on resourcing women in childbirth and protecting breastfeeding in Australian maternity care. So as I've mentioned, Emma is an MP from the Animal Justice Party and was elected to the Legislative Council of New South Wales Parliament. A former psychologist, Emma has worked tirelessly for the rights of humans and animals with an understanding and passion for the importance of keeping mothers and babies together and the important bond between them. Emma also founded the Parliamentary Friends of Women's Health to bring a spotlight to the unrecognised issues affecting women in the healthcare system, and a primary focus of her work has been the space between advocating for greater awareness of the impacts of obstetric violence and birth trauma, as well as endometriosis and adenomyosis. In 2023, she established that birth inquiry into birth trauma, which continues to this day. So thank you, Emma.
Wonderful. And thank you both to Julie and Naomi. I'd also like to begin by acknowledging the traditional custodians on the land on which we meet and pay my respect to elders past and present. I've been invited to speak today because of my work chairing the New South Wales Parliamentary Inquiry into Birth Trauma, which is really a first around the world, examining the issue of birth trauma and also the impact that it's having on women and their babies, as well as families and other people giving birth. The inquiry commenced last year after there was over 200 complaints from Wagga Wagga Base Hospital and 30 official complaints that actually went to the HCCC with some absolutely horrific stories coming out in the media. And I know the organisations actually reached out to my office, that very little was being done in Parliament, and I was quite shocked to hear how many women and how many organisations had reached out to MPs and nothing was really happening. When I started to talk about birth trauma, I also met with researchers at the University of Western Sydney who had recently done research finding that 1 in 4 women have experienced birth trauma in Australia, and 1 in 10 have experienced what we call obstetric violence. This to me was absolutely shocking, and it was cause for me to initiate an inquiry into New South Wales Parliament. And that inquiry has sparked another inquiry. As I said, it was the first in the world that we are aware of. There was then an inquiry that was initiated in the UK Parliament, and I was actually invited to give evidence. The MP, Theo Clark, that initiated that inquiry said that she was inspired by the inquiry here in New South Wales. Our New South Wales inquiry has had an absolutely unprecedented number of individual submissions. Thousands of women wrote into New South Wales Parliament to give their individual stories of birth trauma. And a select few of those actually came before the inquiry and gave their personal stories to the committee on camera. And you would probably have seen a lot of those stories recently in the media. They're extremely brave individuals to come forward and to make themselves that vulnerable, but they've made themselves that vulnerable because they want to see urgent change. We've heard stories during this inquiry of women who have been refused pain relief, women who have been mocked because they didn't know how to breastfeed with their first baby. And we've heard stories of individuals experiencing prejudice and racism, I mean, the stories have just been absolutely horrific, and I won't actually go through some of the most horrific stories now, but I'm sure you've probably heard stories yourselves of what is exactly happening within the maternity care system. And of course, a lot of this is due to the failure of governments to fund most of the care that's actually needed within that maternity care system. So there's a lack of funding for services that are required for people who do have difficult births. We've heard from psychology organisations that not an adequate number of psychology sessions are being funded. We're hearing from physiotherapists that believe that they could significantly help people who have had traumatic births to heal. Again, there's a lot of access issues for many people. And of course, even as simple things like training for healthcare professionals around trauma-informed care, and as well as major programs that we know will help avoid birth trauma. When we're seeing statistics like 1 in 4, you would think that the government would already be funding and making sure that there is funding going into the services that we know will ensure that people can actually avoid birth trauma. But the services that we know, such as midwifery, continuity of care, we know that those models are extremely beneficial and will help people to avoid birth trauma. And yet people who are in most need of these services are actually being risked out of these services because there is inadequate funding to ensure that everybody has access to things like midwifery, continuity of care, which is an absolute, an ongoing problem as well. We've also heard from expert witnesses, particularly around the breastfeeding space. We've heard that people who have experienced birth trauma have been left feeling dehumanized, disempowered and violated. And we've also heard that from a lot of these breastfeeding organizations that breastfeeding and birth trauma are inexplicitly linked. In fact, one witness said, and I'll actually quote them, "As soon as someone is talking about their breastfeeding problems or their experiences after birth trauma, they always speak about their birth." We've heard some absolutely harrowing stories of mothers and babies being unnecessarily separated and kept unnecessarily separated. We've also heard stories where mothers who have just given birth don't have any healthcare professionals around them when they've been separated from their baby, and how that actually affects breastfeeding as well. And of course, that highlights another funding issue in the fact that we've are understaffed in regards to midwives, in regards to nurses. These professions are severely underpaid. And of course, they're already being absolutely stretched beyond their limits. And again, so we're looking into things like nursing ratios to ensure that that care that is so desperately needed is all part of the desperate need for change in maternity care. And of course, when it comes to breastfeeding, as a member of parliament that represents the Animal Justice Party, I'm really concerned about the impact of the dairy industry as well, both on the animals who suffer and in terms of the environmental impacts on emissions. And of course, there's still sometimes we're hearing that there's conflicting and confusing advice, and people are being pushed to use cow's milk formula when we know that cow's milk formula is not ideal for newborn babies. And as I say, there's also that animal welfare impact with mother cows being separated from their newborn babies who are killed in the dairy industry so that the milk can be taken and given to humans for consumption. So there are so many complex areas. I've come in today just to give an introduction. I know that we've got a very exciting agenda ahead to explore the themes and problems that have resulted from the government's failure to actually prioritise and invest in high quality maternity care and implement policies which will prioritise the interests of mothers and babies. Just in some final remarks in regards to where our inquiry is headed and where we've been. So we've had several hearings since the inquiry was initiated last year. We've wanted to make sure that we've also gone to rural and regional areas because we know that some of the concerns and some of the funding issues are quite unique when you actually go out to some of these rural areas as well. So we've had 2 regional rural hearings and we've had several in Sydney as well. We've heard from experts, we've heard from organisations. We have finished our hearings. We have almost finished going through and publishing all of the submissions that were made because there were so many submissions. The committee team has had to make sure that that process is done appropriately and that people who have come forward with information are clear about whether or not they want that information to be confidential or name suppressed, or whether they're happy to really put that information out there as part of the inquiry. We're now in the process of starting a draft report, and I'll have a draft done this week. I'm also meeting again very soon, I think the week after, with Theo Clark, who's the MP in the UK. They are also putting their report together and they will have a draft, I think, at the end of next week. And they will be launching their report at the end of May. And our report will come out at the end of June. Before our report comes out and after I've drafted the report, there'll be a process where other members of the committee can seek to put up amendments to that report. And of course, there will be recommendations through that report in regards to what we heard at the inquiry and what we need to make sure that there were changes we would like to see the government to make. We've also seen our work, talked about right across the media. There's been a huge amount of media attention on this. And I'm seeking a meeting with the health minister as well before that report comes out because we want to make sure there's some really strong recommendations. I think given the media interest and the significant number of submissions we've received, it's going to be very difficult for the government to ignore the report that we come forward. Obviously, going forward, we need a lot more conversations about this in maternity care and in the political space. We need this to be a much bigger priority for governments. We need a massive shake-up in the maternity care system, and I really hope that these conversations and these inquiries are going to spark that massive shake-up that we really need to really help make sure that the funding is put in where it's needed.
Thank you so much, Emma. We really appreciate you joining us tonight and sharing particularly where you're up to and what the goals and ambitions are for the next little while. We really appreciate your time. Thank you so much.
Thank you.
Okay, and just to keep things moving along, Charles, we have Charles Maskell-Knight joining us now, who will be presenting Follow the Money, which sounds very interesting. I'm looking forward to hearing this one. I'm just going to share my screen and hopefully I get the right one.
Well done, Emma. You've absolutely nailed it.
You can see them?
Yes, thank
Beautiful.
you.
I'll start slideshow then.
Okay, thank you very much. So, good evening, everyone. I'd like to acknowledge the Yuin Nation as the traditional owners of the land on which I'm speaking this evening, on the New South Wales South Coast. If I could have the next slide, please. So what I want to do this evening fairly quickly is basically a sort of introduction. Why does the Commonwealth fund state public hospitals? How does it do it? And what are some of the implications that I can see as a result of that? Next slide. So essentially, there's a grand bargain. The Commonwealth government, when it introduced Medicare, promised that it would offer free public hospital services. The only problem with that is that the Commonwealth didn't own any public hospital services to allow that to happen. The other side of the bargain is the state governments, which have got, at the last count, around 700 public hospitals, which are very expensive to run. So the answer to that, clearly, next slide, is...
Excuse me, Charles. I'm just going to stop sharing and switch screens because I believe it's not in the full view. Sorry about that.
All right.
Play from current slide. Okay, sorry about that.
Okay, so next one, please. So essentially, the Commonwealth government bribes the states to provide free public hospital services, and the states take the bribe because they can't afford not to. And some of you are probably old enough to remember the Cold War and the notion of mutually assured destruction, which meant that neither side could afford to start a war because both sides would be reduced to smoking heaps of embers. And it's sort of like that relationship between the Commonwealth and the states as far as public hospitals is concerned. And why is that? Next slide. The cost of running public hospitals is a fair chunk of state budgets. In fact, I think it is probably the largest element in most states. And Commonwealth funding accounts for a little under half of that. So any state which wanted to go it alone, say, we're not going to take your money, Commonwealth, would have to make up a lot of money. And when you think about the fact that about half of people using public hospitals are aged 65 years and over, and about half of them have got absolutely no capacity to meet anything like the full charge. When you think about relying on private health insurance to make up the gap and make private health insurance premiums go up about 3 times, you can see that it's not a politically viable solution for the states. Next slide, please. So how does the Commonwealth do it? Between the start of Medicare in 2014, there was a system of block grants. For the first few years, the Commonwealth effectively paid the states for the private health insurance revenue that they lost as a result of the introduction of Medicare. After that, there was a system of block grants that were indexed for population growth and price increases. In 1998, the Commonwealth finally accepted that there is actually sort of underlying trend towards hospital utilisation going up, and a utilisation factor was built into the formula after that. But having said that, though, the block grants are effectively block grants. They bore no relationship whatsoever to what hospitals did. Next slide. And the grants are often paid to a state treasury bank account, not even to the Department of Health. So how much each public hospital got was entirely a matter for state governments. There was no visibility whatsoever of where Commonwealth money went. And the renegotiation of these arrangements were often characterised by a lot of finger pointing by Commonwealth ministers, pointing to new stadiums in state capitals and arguing that's where the Commonwealth health money had gone. So a new regime dawned in the 2010-2011 agreements between the Commonwealth and the states. Next slide. And that saw the introduction of activity-based funding, aka case mix. And case mix had been introduced as a funding mechanism in America for their version of Medicare in about 1984. State governments had started using it in Australia about 10 years afterwards, but it wasn't until another 10 years before the Commonwealth decided that it would use it to work out its contribution. So under this regime, each local hospital network or local health district or whatever the state version of it is, forecasts how much activity they're going to provide using a case mix classification system. And those classification systems now go beyond admitted patient services to emergency department and outpatient services. The Commonwealth then pays an amount based on that projected level of activity direct to the local hospital network through what's called the National Health Funding Pool. And there's then a retrospective reconciliation against the actual level of activity that was delivered. Next slide. So the level of Commonwealth payment is a proportion of the national efficient price, and there's a body called the Independent Hospital and Aged Care Pricing Authority, which sets a national efficient price of an average hospital service every year. The Commonwealth level of Commonwealth payment varies considerably from state to state. In the Northern Territory at the moment, it's just edging up to 30%, but in some other states, it's almost 45%. It really doesn't matter because it's all washed out by the Commonwealth Grants Commission. So if a state has a low percentage of its public hospital costs being met from under the National Health Reform Agreements, it gets a proportionally bigger share of the GST distribution. Next slide. So under these arrangements, as I said, the Commonwealth pays between 30 and 45% of the cost. Under the agreements, the states are responsible for paying the balance of the cost. State payments to LHNs also flow through the National Health Funding Pool, but it's still a matter of state policy about how much a hospital gets. So, and while most states use a version of case mix funding, there are all sorts of odd bells and whistles and tweaks and smoke and mirrors get added in to work out how much a hospital actually gets at the end of the day. So, next slide. I should say, for the sake of completeness, that there are still some Commonwealth funds paid as block grants, but they're mainly for small rural hospitals, and from the point of view of this evening's discussion, they're not particularly relevant because they don't relate. Those small rural hospitals aren't going to be delivering maternity services. If you're a large enough hospital to be delivering maternity services, you're large enough to be funded through the case mix activity-based funding arrangements. Next slide. So what are the implications of all this? So you can sort of track Commonwealth payments to LHNs, and you can, if you were keen enough, you could probably work out how much of that money is in respect of the projected level of activity for maternity services. But having said that, there's no requirement for those funds to actually be allocated to maternity services. A state, a local hospital network or hospital management can allocate money where they want. There's no sort of radioactive label attached to the maternity money which flows from the Commonwealth to make sure it actually arrives in the delivery suites. Next slide. And the other quite important implication, I think, is that ABF essentially pays for what is, not what should be. So the Independent Hospital Pricing Authority calculates the national efficient price as the average cost of actual service delivery. And the National Health Reform Act, which sets the statutory framework for them, actually refers explicitly to having regard to the variables affecting the actual costs of providing healthcare services. So if, from a policy perspective, someone wanted to allocate more funding to maternity services, it's quite difficult to do it through activity-based funding as it's structured at the moment. And even if the Commonwealth were to provide additional funding for maternity services, if it were to essentially rig the numbers to pay for what should be, not what is, the state still has to agree to flow that through to maternity services. And the temptation for the states, of course, if they get more money than they need to pay for what they're doing now, is to take some of the money they're allocating to maternity services and allocate it somewhere else. So that's a fairly quick summary. I should say it's particularly quick because it's my wife's birthday and I've got to go and cook dinner for her. But I've probably got time for a question or two if they haven't appeared in the chat yet. Thank you.
Thank you so much, Charles, and say thank you to your wife and happy birthday as well. We really appreciate you giving up your time and for that really good overview of such a complicated system that we work and operate and live in our federalised system, and it really helps to see the complexities around where the money comes from and goes and who makes the decision. So I really appreciate that, and I'm sure everyone else does as well. There aren't any questions in the chat box at the moment. Oh, hang on, we do have one in the chat, but it's more about birth trauma, so probably not one for you. So we might let you go and enjoy
Thank
your
you very much.
birthday dinner. Thank you very much.
Okay, thanks. Bye.
Next, we have Monica Costa, who will be talking with us about gender responsive budgeting for baby-friendly maternity care in a federal system. So a beautiful topic to follow on from Charles. Thank you so much for sharing your screen, Monica, and I'll hand over to you.
Sorry, yeah, I was probably too quick at sharing my screen, wasn't I? Too keen. Hello, everyone. So I'll be talking to you about a little bit about gender responsive budgeting, sort of giving you a bit of the introduction to it and sort of highlighting some of the links that are emerging between gender responsive budgeting and maternity care. And I'll start with the beginning, really. What do we mean by gender responsive budgeting is a strategy to incorporate, to mainstream gender into policies and budgets. It typically involves these two dimensions. On one side, a really big attention to analysis, to how research, how analysis reveals the gender differentiated impacts of budgets and policies. And on the other side, using that information, that knowledge to really shape better budget process policies and priorities to obviously promote gender equality. And this sort of comes out of the recognition that women and men have different economic, political, social circumstances, positions. And as a result, their choices, their opportunities, their needs are different. And the way policies and budgets impact on them are also different. Why does it matter for talking about maternity care? I think Charles probably sort of made the link already. It's really important for the services that we get. In a way, the budget turns the commitments, the plans, the policies into reality, right? And this is how gender responsive budgeting became such a big idea across the world. More than 100 countries have introduced elements of gender responsive budgeting. And that's primarily because of this link. Without the money, we're still talking about plans. On the another point is that budgets reflect what's valued and what's not. And this is probably illustrated during COVID and when the government decided that their recovery package would primarily address, the recovery package was primarily focused on male-dominated sectors of the economy, and women mobilized and sort of show that really women were the greatest group impacted by COVID-19. So it shows us what the government sees, what's valued, what's important. And another element, of course, of that is the assumptions about what is economic, what is productive, paid and unpaid, and how they're underpinning the economic policies. This is sort of brought to light in the past budget and in the discussions and changes to the single parent payments. If you would remember that a lot of the discussions around single parent payments were about recognizing women and women's work, unpaid care work, which was being sort of undermined, challenged by increasing pressures for women to return to work. And of course, gender responsive budgeting provides an avenue. So the budget is another way of sort of connecting with women, being accountable to women and the commitments in maternity care. When we talk about budgets, we sort of talk about two types of impacts. We talk about the direct impacts, which are the sort of the policies around, for example, income transfers, single parent payment, for example, maternity leave, measures around breastfeeding and childcare. But there's also these other indirect effects, which are around procurement, the private sector, the way the government shapes the private sector through their supply contracts, workplace regulations, and of course through the broader sort of macroeconomic priorities and what the government sort of puts their emphasis on. Now, gender responsive budgeting is back in the agenda in Australia. So Australia was, and I know some of you know, but was the sort of the grandmother of gender responsive budgeting in the world. As I said, more than 100 countries do it now, but it all started here at the federal level in 1984. And for a very, very long time in different ways, governments, both territory and state governments and federal governments produced what we called a women's budget statement. They disappeared officially in 2014 when the Abbott government ceased publishing a women's budget statement. But they have now returned to the agenda and across Australia. Really. Queensland was the first one to return a women's budget statement, but now we've got gender budget statements in Victoria, women's budget statements in the ACT, sort of across. They're quite varied. A women's budget statement is a part of gender responsive budgeting. It's used by governments as a record of how policies impact on women and men, and also about their priorities for women or for addressing gender equality. So they use it as it's usually connected with the budget, and it's usually a document, could be a very short document of 4 pages, like South Australia. It could be a very long document of several hundred pages. And they show us what the government is prioritising to address inequality. And this is an example from South Australia. And sort of a big feature of the Women's Budget Statement is that it makes the government accountable to women. It tells tells women as a group how the government is prioritising to address issues that they value, right? In this case, South Australian government is telling women about how they're going to improve the quality of health services, and they're going to increase the number of spaces in the hospital, the new Women's and Children's Hospital. And then they go on and talk about all the work they're going to do for pediatric intensive care unit. And this is interesting for 2 elements. One of them is the focus on big hospitals, sort of the big infrastructures in the health sector, and also the connection between women as mothers. So this is the way they talk about these issues in the statement. It shows you how the statement can be a powerful tool for women's organizations and researchers about sort of the way the government is framing this conversation. One of the important things in gender responsive budgeting is to make visible unpaid work. That's one of the areas where there's been a lot of work, and really a lot of important work. You'll know that unpaid work is really important for the economy. It's a really big part of the economy. That many women contribute to the unpaid economy, but they do different things, and women tend to do more than men. And this was really highlighted during COVID-19 or the early days of COVID-19. And then another important thing is that unpaid work supports not only families, not only communities, but also the paid economy. And so this has been an area where feminist researchers and advocates around gender responsive budgeting have been working on. A really important thing is the connection between budgets and unpaid work, right? So decisions in the budget have an impact on unpaid work. For example, paid parental leave affects breastfeeding, right? Decisions to cut health services affect families' capacity, work capacity. If you can't have your sick people, sick family relatives in the hospital, then somebody has to be home caring for them. And I love this little sentence or statement that was recovered by Julie Smith during the COVID-19 pandemic about women not being the babysitters of the economy, which was what was happening. It's sort of connecting these two, the economic, the budget, and unpaid work. And this is a quick reminder that this is how we think about the economy, as being a very tall cake with many, many different layers. Only the ones that are visible are the ones on the top, but they are dependent on the ones on the bottom, on the voluntary work, the family, the community, the unpaid work, and also sort of the natural resources. Now, I'll just turn very quickly to the role of community sector organizations, researchers, sort of using this knowledge to shape maternity care and policy and funding. And I start with this little wonderful little sort of snapshot from Victoria. So this is a women's health service network, and they've produced a report card of the Victorian state budget in 2023. So they look at the budget, they see what the budget is saying, what the government is saying that they are going to deliver for women in health. They talk about their own priorities, what they prioritize, and then they give an assessment at the bottom about all the things that they agree with the government and all the areas that more work needs to be done. So this is an example of where women are using their knowledge, are using their networks, the knowledge of the networks with whom they interact, to then use this information to try to shape budget decisions. Another example a bit closer to home is the work of around sort of the research around breastfeeding, or the work that Julie Smith and many others have done about the economic value of breast milk production, which was estimated to be 2.1 billion in 1992 values. But also the work done around how much of economic input would be derived from supporting breastfeeding. So this was some earlier work sort of estimating the contribution, the economic role of breastfeeding. More recently, the work that was done since 2017 using the World Breastfeeding Costings Initiative, trying to put a cost. How much does it cost to actually do something about this? We want to achieve these outcomes. We want to get here. How much would it cost for us to put some money where our commitments are? And this has been sort of driving some of the discussions. I think that's a really interesting example. And I'll sort of close with this little example from Indonesia, which really connects sort of the analysis with change. So in South Lombok in Indonesia, there was an area that had very high maternal mortality rates. Women's organizations went there, had a look at the problem, tried to understand what the drivers were, issues around culture, issues around poverty, and use that information to then review the budget. Okay, so what is the government saying? This is what we know about the problem. This is what the government is saying they're going to do to solve the problem. The government was more focused on things like building hospitals and getting more doctors on the ground. But their consultations, their engagement with the community show that women really would prefer more midwives, would prefer more connection with actually the health services and the health service to be more connected to them, more close to them. And they would have preferred to have motorbikes, those midwives to have motorbikes and have sterilization materials to get to them quickly. So there was a sort of a tension between what the government was saying their solutions were and what the people in the community and the communities were understanding their solutions there should be. Now, they've used that information to then try to lobby the government, advocate the government to change their priorities. And were successful. So the government not only redirected funding, but also increase the percentage of funding that was going to maternal health issues. So this is an example of where analysis is used, understanding of the problem, where the drivers, and then using that to shape how policies come together, and in some respects, sort of the role of civil society organizations contributing for that discussion, which is really important. It was one of the outcomes of the history of Australia. And anyway, keep posted. Rhonda Sharp and I are writing a casebook about gender responsive budgeting in Australia, which should be coming out very soon. But I think that's pretty much the highlight of what I wanted to say. Thank you
so much, Monica. It's really good to have you join us again, and I'm excited to see that work when it's ready. So important that the particular needs of women are recognised when it comes to budgeting, and also all that unseen care work that goes on, and important that that is measured and valued. So thank you, Monica. We do have questions, but are you okay if we save that to the end? Yeah, beautiful. Thank you so much. So we have Carleen Gribble joining us next from Western Sydney University, who will be speaking about adherence to WHO guidance on maternity care during the COVID emergency. Thanks so much, Carleen.
Okay, I will just get my presentation up. And I'm going to hopefully whip through it all within the time frame allocated. There's quite a lot here. But as you know, we had massive COVID-19 pandemic that impacted everybody around the world, and was of particular concern when it came to infants and mothers, because what we normally do when there is an infectious disease is we separate the people who are infected from the people who are not infected. But that's a problem if you're talking about a newborn baby and their mother. We were fortunate with this particular infection in that it did not actually impact infants very severely. And so it was quite clear from early in the pandemic that we should be prioritising keeping mothers and infants together and supporting breastfeeding. And in fact, the WHO on the 13th of March, which was only a couple of days after the pandemic was declared, published their clinical guidance on COVID-19, and that included a section around mothers and infants, and they recommended no change to standard care practices for newborns, except mothers washing their hands more and wearing a mask, but they recommended keeping mothers and infants together, skin-to-skin contact and breastfeeding as you would, it was really a very good thing that WHO came out with this early. So, but what actually happened on the ground together with a group of people, and I think Roger is also here in the audience. So we worked together with Jen Cashin and Kathy Marinelli and our colleague, our other colleague in Vietnam, to do this research where we actually did 2 lots of data collection. I'm just going to present the second lot of data collection, but we looked at what happened around the world in terms of how were mothers and infants being treated. Now, as I go through this, you're going to see all of the data, but I'm going to focus on Australia because that's where the majority of the audience is. So 101 countries, so roughly half the countries in the world were in our data set. So we did quite well in terms of collecting lots and lots of countries. And we compared what was happening with what WHO recommended. So they recommended skin-to-skin contact immediately after birth, early initiation of breastfeeding, direct breastfeeding, rooming in, which meant mothers and infants close by one another, not just sharing a room, provision of express breast milk where mothers and infants were separated, wet nursing where mother's milk was not available, breast milk substitutes in circumstances where you didn't have mother's milk, relactation where mothers had not initiated or ceased breastfeeding, and psychological support for both mothers and infants who'd been separated. I'm going to flick through these maps showing what happened around the world, so you'll be able to see what happened with Australia. I think what's particularly significant for Australia is actually the situations where we had no recommendations, but you can see the red is where countries recommended against what WHO was saying. Orange was where there were conditions around whether the recommendation should be made. Green was where they were in alignment with WHO. Grey, no recommendation. White, where the countries that we didn't have data for. So you can see skin-to-skin was recommended in Australia, but was not necessarily recommended in some places, and no data for about a third of the countries. So it just wasn't mentioned. Early initiation of breastfeeding wasn't mentioned in Australia. Again, was quite about a third recommending that it happen. Quite a lot of countries not recommending early initiation of breastfeeding. Rooming in was very complicated. Australia was a country that did recommend it, but many countries did not, or recommended room sharing, so having the mother and baby in the same room, but separated by a certain amount of distance or behind a screen. Direct breastfeeding was often recommended, and I should have highlighted this data was actually collected at the end of 2020. So it was November and December of 2020. So quite some time after we had a lot of information about COVID. Again, Australia in green. This was the most recommended recommendation around providing express breast milk, but there were still 4 countries who did not recommend that mother's milk be provided if the mother was infected with COVID, including countries like Japan and China. So places where there, well, when it comes to China, a lot of babies born. Donor human milk was barely recommended, wasn't recommended in Australia. Of course, we do not have sufficient donor human milk for the babies who require it in Australia, and certainly wasn't being provided during COVID. Wet nursing almost recommended by no countries at all. And it's been acknowledged that there's an issue around countries not being confident with wet nursing, not knowing how to use it. And so there's in fact brand new guidance coming out from UNICEF around wet nursing in emergencies very, very soon. There was a webinar last week that the Infant and Young Child Feeding in Emergencies core group ran on this, that should be online if you're wanting more information about that. But it's a really interesting issue. Relactation, again, barely recommended, only in a few countries. Breast milk substitutes being appropriately recommended, again, barely recommended around the world. And these, I thought these last two, I think, are really important and interesting. And I'm going to highlight where this was an issue in Australia. But psychological support for mothers was only who were separated from the infants was only recommended by just over a third of countries. It did include Australia. But when it came to psychological support for infants separated from their mothers, barely there at all. Wasn't in Australia, wasn't in very many countries. And as I'll describe later, I think it's exposing a significant problem with infants actually not really seen as being people and in need of psychological support. So when we look at overall alignment with WHO guidance, we can see Australia's sort of middle with 6 out of 11. Not as bad as some, not as good as others. So Norway and Italy did the best. But, you know, some places, so 0 for China, 0 for Japan, really quite dire. And the US also did very, very poorly. They did not, they still don't recommend breastfeeding if mothers and infants, if mothers have COVID, and they just don't make a recommendation. So really, really unhelpful. So although Australia generally did quite well in terms of recommendations for where mothers had COVID-19, so recommended breastfeeding, recommended rooming in, recommended skin to skin, so those really 3 crucially important ones, it was not all happy and good. So we had some really significant problems. So this is an example, and there was particularly where babies were ill, like small, sick newborns. So this infant was born in Lismore, was flown to Brisbane to be cared for in a neonatal intensive care unit. The mother was left behind. The border restrictions meant that she was not allowed to accompany her baby. And this was something that happened consistently. It was the lack of understanding of the special circumstances of a mother and her infant were not understood in many, many policies that when it came to COVID-19. So another example, COVID-19 outbreak at John Hunter Hospital, you know, what was actually happening there in terms of mothers and infants? What did they do when infants were no longer, so parents were not allowed into the NICU while the outbreak was in place? What did they do to support those infants who were separated from their mothers? They didn't, as far as I know, increase the number of staff available so the psychological needs and emotional needs of those babies could be met. They just carried on as usual. Another example on the right, this is from Victoria, a NICU that was only allowing 2 one-hour visits per day for one parent to be with newborns. So in the NICU, so really like terribly restrictive practices. And this is a sort of policy that was quite common. So this is the Royal Women's Hospital in Victoria. They had quite, in many respects, generous allowances. They did talk about visiting, and I think that's really inappropriate language when you're talking about a mother and her infant. Mother is not visiting her baby. There's a mother-infant dyad. So it's the physical presence is really important, but this is not visiting. However, they treated both parents the same, so the mothers and fathers the same. Only one could be with the infant at a time. When you've got really generous, like sort of 24-hour visiting allowance, that's not such a big deal. But in some places it was only 1 or 2 hours a day. It's from different times. And so if you were only allowing one parent at a time, you were actually decreasing the capacity of mothers and infants to be together. And so that, you know, was a really significant problem. I'm just going to this very quickly, if it will work for me.
And I've come here, I've had a baby last week. I've got a 7-day-old baby. And the baby, unfortunately, needs the mum because for breastfeeding purposes.
So that was again illustrating a really common circumstance where there was not an understanding that this is a different situation from normal, that maybe only the person receiving treatment was supposed to be allowed, but you should make an exception for a newborn infant. And I think this is my final example. This mum had to have major surgery. She had and was hospitalised for a number of weeks. She had an exclusively breastfed 4-month-old baby, but the hospital applied the same visiting allowance to this baby as what they would to anybody else. And it resulted in not only this mother ceasing breastfeeding, but actually it really significantly impacted the infant's trust of their mother, and she rejected her for quite some time after they were reunited, and they really needed to work together on that relationship. So it was really quite tragic. So continued problems with COVID-19 quarantine around not having provision and things actually being quite dangerous in many circumstances in COVID-19 quarantine for mothers and for families with their infants and young children, really actually extremely dangerous. I did some research on this. I've never before had to I was contacting ministers for police and health and saying you need to do something. Somebody's going to be very badly injured or killed potentially. What we saw during COVID was a lack of knowledge and respect for the mother-infant diet. And what we saw was a veneer of support for breastfeeding and proximity for mothers and infants was stripped off and really revealed what people thought was important and unimportant. So I'm just going to briefly mention some of my other other emergency work. So an audit that was done as a part of a WVTI assessment some years ago, looking at what we had in terms of emergency planning and guidance for infants and young children in Australia, showing essentially nothing. Emergency organisations have not stepped up in this area. The Australian Breastfeeding Association did, and I've been working with them and for them with the Community Protection for Infants and Young Children in Bushfire Emergencies project. That's our report there if you want to know what it is actually like to be in an emergency. If you're a pregnant woman or a mother or parent with an infant or young child, you can read about it there. These are my publications around emergencies, around COVID, and as well as some, yes, so I think they're all the COVID ones. And articles in the conversation around this. I think my colleague Nina Chad and I, we got to the point where we kept waiting for authorities to actually provide guidance to parents and to provide that support, and it wasn't happening. And so in the end, we have actually just put it out there in the conversation, and interesting, some of the state and territory emergency and health authorities have actually kind of plagiarised our stuff and have used it there. But yes, I'd like to thank you very much for asking me to speak. One thing that I would like to mention that occurred to me when I was listening to Emma speak, some of you may remember the Best Start inquiry that was conducted in Australia in 2007. I made a submission to that inquiry, and in that submission, I raised our lack of pandemic preparedness around infant and young child feeding. That was a long time ago. I don't know that many people had read Australia's pandemic preparedness plan at that time, but I had, and I knew there was nothing in there. And it showed if you don't have good planning in place, if you don't have good guidance, if you haven't made the investment to put things in place when an emergency comes, what happens is not good. It is not a good time to be working out what to do when you're in the middle of the emergency. You need to be prepared beforehand.
Thank you so much, Carleen. Really interesting to have that data to be able to look back and see what actually happened during that pandemic and how unprepared so many services were for the needs of mothers and babies. really valuable work. Thank you. Next up, and I'm sorry, we do have to just keep moving so that we get to hear everyone. Next up, we have Dr. Andini Pramano speaking to us about her work on the social value of maintaining the baby-friendly health initiative accreditation in Australia. Thanks, Andini.
Thank you, Naomi. Can you see my slide now?
Yes, we can. Thanks.
Okay, thank you. Thank you for the opportunity. I will start the timer. This paper has been published, and this is part of my PhD thesis, and it was written with my supervisors, Julie Smith, Jane Desborough, and Joan Burke. I would like to begin by acknowledging the traditional custodians of the land on which I live and work, the Ngunnawal and Ngambri people, and pay my respect to elders past and present. So briefly about the 10 steps and BFHI. So WHO and UNICEF launched the 10 steps in 1989 and then revised in 2018. And also baby-friendly hospital initiative in the global setting in 1991. The 10 steps is a framework of how maternity facilities should educate and support women and families in regard to breastfeeding, whereas BFHI is a program that encourages maternity facilities worldwide to implement the 10 steps. A lot of research showed that 10 steps and BFHI are positively associated with higher initiation rates and prolonged breastfeeding duration. Briefly, in Australian setting, in principle, the Australian government supports and promotes breastfeeding. National Health and Medical Research Council has published Australian Dietary Guideline and Infant Feeding Guideline for health workers, which supports and encourages breastfeeding. BFHI has been recommended to be integrated into national accreditation standards since 2007 through Best Start report. Again, in 2010 and 2019, Australian National Breastfeeding Strategy recommended the same. Sadly, there is lack of follow-up action. Currently, only 21.4% of Australian hospital was baby-friendly accredited. So, for this study, I aim to examine the social value of maintaining the BFHI accreditation in one public maternity unit in Australia using the social return on investment framework. The study conducted in Calvary Public Hospital. Now it's called North Canberra Hospital in October 2019. To estimate the cost relating to the BFHI accreditation, we interviewed the Director of Maternity Services and the clinical midwifery educator. The interview was guided by the questionnaire, which we developed based on the 2018 10 steps. The analysis that was supported with peer-reviewed literature on the benefits of breastfeeding. So briefly about the method, the social return on investment. The SRI framework accounts for value in a broad sense, measuring change in terms of the social, environmental, and economic impact. We established scope of the analysis. This identified what we measure, involved stakeholder in the process, mapped the changes, collected evidence and values for inputs or investment and outcomes, calculated the SRI, and conducted sensitivity analysis. So this is the results. This table shows the value of benefits and costs. For babies, benefits included risk reduction of diarrhea, respiratory infection, necrotizing enterocolitis, obesity, type 1 and 2 diabetes, and IDS, as well as higher IQ. For mothers, benefits included risk reduction of breast and ovarian cancer, cardiovascular disease, and hypertension, as well as no cost for buying formula milk. The cost in achieving BFHI accreditation is based on interview findings. So from the calculation, the social return was calculated to be $1,375,000 Australian dollar, and total investment required was more than 24,000 Australian dollar per year. Therefore, the SRI ratio was 55:1, which meant that every $1 Australian dollar invested in the BFHI in this hospital generated approximately 55 Australian dollar of benefit to the Australian economy. The study measured the benefits compared to the cost invested by the hospital. However, our study did not include cost savings for healthcare providers, which were not taken into account due to large gaps in the literature relevant to the Australian health system. There is also no literature on the benefits to healthcare professionals in implementing or achieving the BFHI accreditation. Moreover, mothers' time and effort to breastfeed were not included in the calculation, with only limited data on this important investment available in the current literature. The impact of breastfeeding support programs on mothers is well documented. However, elucidation of the SRI from mothers' perspectives would be great value in further clarifying the social impact of implementing the BFHI. So in conclusion, investment in breastfeeding support programs, including the BFHI, benefits the community. As the social benefits are greater than the investment, and it provides the best start for every infant, the BFHI needs to be prioritized by the government. Our evidence quantifies the value of the BFHI program, identifying economic value for investment. Strong incentive for governments to invest more in motivating, implementing, and maintaining BFHI accreditation in all Australian hospitals. BFHI accreditation is a way to ensure equitable quality maternity care, but lacks incentives for individual facilities in Australia's health financing system. In fact, hospitals are funded on how many patients they receive. So in broad sense, hospitals get more funding if babies return to the hospital rather than if they leave hospital exclusively breastfeeding and healthy. For our upcoming project, in early this year, we just got an MRFF grant, and this project is called Scaling Up the BFHI in Support of Maternal and Newborn Health. This study will ask whether all birthing women in Australia have had equal opportunities for breastfeeding support by hospital discharge. It will examine links between where BFHI hospitals are located, social factors, breastfeeding, and health. It will also survey potential mothers on the importance they place on the BFHI 10 steps, and it will improve resources and practices so more mothers get linked to the support they need for breastfeeding success after childbirth, will advance health and health equity. Thank you.
Thank you so much, Andini. It's really, really wonderful to see this up-to-date research work happening and focus on BFHI in Australia. We've seen in other contexts around the world how beneficial BFHI is to breastfeeding and to mothers and babies. So great to see a focus on it in Australia, and I look forward to seeing the future work that's coming along too. Next up, we have Professor Jenny Gamble from Coventry University in the United Kingdom. And Professor Jenny Gamble will be speaking to us on value and impact from funding arrangements in maternity care. Thank you so much, Jenny, for joining us.
Hello, everybody. A pleasure to be here. Now I just have to make sure that I transition to my screen properly and make that available to you. Okay, we in business?
Not as yet. Oh, there we go. There we go. Thank you.
Excellent.
It's early.
All right.
Here, Jenny.
Hello.
Hello. We
Can
can
you
see
hear me?
now. Thank you.
Okay.
Yes.
So am I on the slideshow from the beginning, or have I got it displayed properly?
You just need to click from the beginning.
Okay. Let me go to that.
your,
Mm.
there we go, from
There
the
you go.
beginning. Thank you.
Lovely.
Yeah.
No, thank you so much. Okay, so I'm Jenny Gamble. I am Professor of Midwifery at Coventry University, but I'm Australian, and most of my academic career, and in fact clinical career in Australia, but not solely that. I'm talking to you today about the value of maternity care in terms of money. And I'll talk to you about 5 papers, and I've got them color-coded here just so that we can keep track of them. The one I'll focus on the most is the value of maternity care in Queensland paper that was done with data from 2012 to 2018. But I'll also talk about the other papers as they intersect with continuity of midwifery care, home births, and my last paper will talk about hospital accreditation. I quite like that paper, so I've slipped it in because I think about how we drive the system with a view to what does cost effectiveness and funding look like, but what also does our regulation and supposedly regulatory processes to enable evidence-based care to be widely available to women. And I was very pleased to hear our opening remarks by Emma Hurst. For my PhD, I developed and tested a counselling intervention for women that had had a traumatic childbirth. We later did an implementation study around that, and we also used it and modified it for women who were fearful of birth. And basically all of that early work, and even then, preceding that, I did women's preference for a caesarean section. All of that early work, plus my own clinical career, plus my own experience as a mother, really has made my full focus now on access to continuity of midwifery care, because it ticks lots of boxes in terms of our ability to deliver other evidence-based interventions, but also and primarily because women want it, women like it. When they get it, they come back for more, and it improves outcomes all sorts. So that's where I sit in this world of maternity services. Okay, let's talk about the first paper first. This paper was about the value of maternity care 2012 to 2018, based on analysis of Queensland Health data, all of their own data, and we used it to work out what the costs were like relative to the proportion of births not meeting the criteria for a positive birth outcome. And they weren't surprising things: babies born preterm, babies admitted to special care nursery. They were all the usual things that you would see as not a positive birth outcome. So we looked at the cost per birth to all funders, the public hospitals, the public funders, the women themselves, the pharmaceutical benefit scheme, Medicare. And costs had increased markedly over that 2012 to 2018 period. So the annual bill kept climbing, even though there was a slight reduction in the total number of births, and the proportion of births not meeting the criteria for a positive birth outcome increased to 27%, from 27% to 30% in 2018. So things got more expensive. The overall bill was greater despite less total births, and the proportion of births not meeting a positive birth outcome, we're not even talking about experience, we're talking about outcome, like, admission to special care nursery, hypoxic encephalopathy, that also increased. And the demographic and clinical characteristics of the women giving birth did also change markedly, and the proportion of births without any adverse outcomes declined from 72% to 69%. So what's that really telling us? This study is just really telling us that despite increasing costs, we are not improving the outcomes. It's not really a pretty picture, is it? Still the same study. Costs have increased, adverse outcomes have become more frequent. 38% of women giving birth in Australia had a caesarean, and this wasn't one of the not positive birth outcomes, by the way, an increase in 32% from 32% in 2011. So if we look at the costs, they are largely attributable to much increased medical intervention. longer hospital stays, more babies admitted to the special care nursery. The cost attribution is because we have an increased rate of interventions, and we're having an increased rate of interventions, not necessarily, or not without improving the birth outcomes. And there are arguments, and some of those carry weight, that the demographics of women have changed in terms of, you know, number of women who are overweight or obese, older mothers, women developing preeclampsia, diabetes, and those things are true. But in fact, it is all the more reason to say that we need to move upstream to primary health, social models of health, continuity of midwifery care, the ability to deliver primary care interventions to address some of those drivers of demographic and participant women's attributes around the time they have a baby. So it still is the same picture, even though you understand that the characteristics of the women are changing, the response would still need to be the same. And delivering high value, high quality maternity care requires strategies for containing costs, or either maintaining, I would argue, or improving its quality. Okay, our second paper was a cost analysis paper, so I can get rid of that, for upscaling access to continuity midwifery care, and as a population-based micro-simulation in Queensland. I've got to acknowledge, it's probably worthwhile saying early on rather than late on that Professor Emily Callender, now currently at UTS, leads most of this work. So I'm here bringing my midwifery knowledge. So this paper looked at upscaling continuity of midwifery care in public healthcare system, and we said it's slow and the financial impact was under-researched. Women receiving continuity of midwifery care, I can roll that off the tongue a little bit too quickly, experience numerous benefits without adverse effects for them and their baby. We modelled the cost savings for Queensland to public hospital funders per pregnancy if 65% of women had access to continuity of midwifery care. The cost savings were estimated to be $534 per pregnancy in 2023-24. A total state level annual cost saving with 65% access, which means we have 19 million saved in the 2023-24 year, and if that proceeded, to 30 million saved in the 2030-2031 year. So significant savings for Queensland. This is the same paper. It just argues that enabling most childbearing women in Australia to access continuity of midwifery care would realise significant cost savings for the public health system by reducing the rate of operative vaginal birth. So forceps and vacuum are one of the key experiences associated with traumatic birth. In fact, there is broad agreement. Nobody thinks that women would ever want or choose forceps or vacuum birth. It is associated with significant risk to the baby and to the mother, both short, medium, and long term. And we need to really understand how to reduce that as an outcome of being pregnant, labouring, and giving birth. I've just got a little graphic there that was Queensland Health graphic, and it's based on a range of studies, not only the Cochrane study, and in fact it's probably out of date relative to the Cochrane study. Much of the research that we've done in Australia around continuity of care, some of it feeds into randomised control trials and therefore systematic reviews, but there's a ton of other research that never is not appropriate to use a randomised control method for, and therefore will never be represented in a Cochrane systematic review or a meta-analysis. And I can think of one big program in Australia that fits that bill, and that's birthing on country or birthing in our community with Aboriginal and Torres Strait Islander people in Australia. That's been highly successful in meeting a range of outcomes. But I can also think of a range of other studies and a range of other services that I know that produce amazing outcomes when women are given continuity of midwifery care and the model is set up as intended to deliver the benefits that we know that it can. On that note, I'm in the UK at the moment, and I have to say, take a great deal of care. So I've been here for nearly 3 years, and I've searched this small island but large population for continuity of midwifery care models that are working well, not fragile, sustainable, scaling up, generally accessible, delivering actually a known midwife at birth, and they haven't got it right, despite policy initiatives and reviews spanning back to the 90s when they did childbirth, and then in about 2016 they had the Better Birth policy, great policy, but they have failed to deliver on it because they don't know how, but they don't know that they don't know how. So in Australia, in fact, despite an absence of national policy, and they even had targets here at one point, is doing a much better job at actually implementing continuity of care. And by that, I mean a very small group with a known midwife, a named known midwife. That seems to be beyond them here in the UK. And there's lots of implications for that. Women obviously don't get that model of care, but as a researcher, as a maternity researcher, if the model doesn't exist and the model does not exist in a robust form delivered with integrity, then how on earth do you research the outcomes of it? You have to have it in existence to be able to study what it looks like for women and their babies and their families and communities. Okay, my next study is just the financial impact. Sorry, I'm mucking about a bit. The financial impact of offering publicly funded home births. And again, it's a population-based microsimulation done with data in Queensland because we had it. And I think Emily and her team have plans to do it nationwide. So home birth is associated with fewer birth interventions and a positive maternity experience. No greater risk for babies. Inpatient healthcare costs around birth could be saved if 5% of women plan to give birth at home through publicly funded programs, and the total cost of public hospitals for all births would decrease. So if they want to actually save money, they need to start to think about what those models and programs look like. This paper is about cost effectiveness of public caseload midwifery compared to other models. And again, it shows that there's a 22% less than other models of care if women are given, they call it public MGP in Australia, as most of you know, but it is caseload care or continuity midwifery care by any other name. Women like it, public caseload care produce comparable health outcomes. With some indication that outcomes may be better for lower costs for women. So that the focus of that study was an economic study, but it showed the trend in the right direction. This is the little paper I just wanted to pop in there to talk to you briefly about, and it's about hospital accreditation. So we did a scoping review because we were just a bit fed up by the idea that we have a whole lot of systems and processes, regulatory frameworks in Australia, but none of them actually seem to be supporting the rollout and scale up of continuity of midwifery care. So this was published in 2021, and quite frankly, it took us quite a while. So because it was so complicated, we collected policy level documents, macro level documents, and by the time we'd reviewed all of those, far too many, we ended up with 100 papers, documents, not all peer review papers by any stretch of the imagination, any sort of document that was related to that policy level discussion about hospital accreditation. And we had 100. While we were looking at the literature, of course, we had to look at the notion of hospital accreditation more broadly, like what were others saying about it. And although the system as a whole seems to be wedded to hospital accreditation, there is no clear evidence that it really makes a positive change to the way our health and hospital system runs, and hospital accreditation is primarily about hospitals. So there's controversy, no clear evidence, and calls for change. There's definitely change needed in maternity services in relation to maternity care, and that measuring and implementing the quality and safety of maternity care is just not happening, really. So we propose structural changes to Australia's health accreditation system are needed to prioritise and mandate continuity of midwifery care. Rightio, my time is up, really. These are the papers I've referred to, and then when the other speaker was speaking, I just thought I had a bit of slip in the last little paper, which I've not actually talked about today, about the socio-economic differences to access to care for Australian women who are fearful of birth. The title hides some of the data in the paper, not intentionally, which really shows that women from lower socio-economic groups have reduced access to continuity of midwifery care. And continuity of midwifery care is extremely helpful for women who are fearful of birth. So I just thought I'd highlight that for you and let you know that it exists as a document. Okay, so thank you very much for your time. It has really been a pleasure to be here. And this is me, is my details, including my email address here, and ways to find me, but also a special thanks to Professor Emily Callender and my co-authors for great work. I love doing that economic modelling work, and I'm so grateful that they have the expertise to actually do it, and I can just participate what I can do. Thank you so much.
Thank you so much for that, Jenny. I'm absolutely gobsmacked that we have all this evidence there, and there's some really startling figures there that really demonstrate why it's a no-brainer, really. I guess hopefully in the discussion we can talk about where to from here. You know, we've got that data. What can we do to progress this forward? And we will allow time for that discussion shortly because we are actually running on time. I'm really impressed. Thank you, everyone. So next up, we have Alessandro Alamo joining us to give us a global practitioner's perspective on system priorities for maternity services and infant feeding support in emergencies and disasters. And I can see you there ready to go. Alex, thanks so much.
Thanks, Noemi, and thanks, everyone. Sorry, I usually can't find presentation. Just a second, let me reopen everything.
Okay.
But again, a pleasure being here. A really impressive presentation, really valuable and powerful evidence. Okay, here. Yeah. Okay. Thanks. Just let me put it on screen share. Okay. Can you confirm, Noemi, that everything is visible?
Okay. Thanks, Alex.
Okay. Thanks. Yeah. So, and thanks really a lot for inviting me and for being part of this exciting event. A lot to reflect on and a lot to even to use for our global, national, regional advocacies. So the presentation will be around, my perspective, the perspective maybe of also some of our colleagues, and maybe some of them are also on this call that are working extensively in emergencies and disasters across contexts. And I will try to zero in specifically on the infant financial feeding and emergency context, just to look at where we are in terms of how much we support, our systems, our processes, our resources, how much are ready to support infant financial feeding in particular. But just a snapshot on where we are, what is the world around us telling how women and children are exposed in terms of emergencies and disasters. So the forecast for this year, as some of you may know, all of you knows, is that more than around 300 million people will be needing humanitarian assistance. That's really the basic survival assistance due to various issues, and I think all of us are watching some of those through our TVs and news. Issues related to protection, conflicts remains a major driver, climate emergencies, and others. And this was a forecast of UN OCHA for the 2024, for the year that is currently where we are currently. At the same time, UNICEF was estimating that around 400 million children were leaving or fleeing from conflict zones, and these are children from 0 to 18 years of age. Many are injured, killed, or even sexually violated. At the same time, we also have learned, again through the estimates from UNICEF, that globally, more than 1 billion children live in countries that are at extreme risk from the impacts of climate change. So again, seems clear that children are certainly among those that are mainly or most affected by emergency and disasters of all sorts in all contexts. At the same time, we know how women worldwide are experiencing, unfortunately, or are survivor of gender-based violence, and how this increases in conflict settings. Also, there is widespread evidence that shows how, unfortunately, majority of the preventable maternal mortality does happen in settings where there is conflict, displacement, and natural disasters. So again, women and children, and I know maybe I'm stating the obvious, but we do have sufficient evidence that shows how these two groups in particular are among the most affected across all our emergency and disasters and across all the various contexts. So contexts like Japan, like Australia, like Italy, my own country, or other contexts like currently Ukraine, Afghanistan, or Gaza for that. And in the recently released global report on food crisis, unfortunately, once more we see how almost 300 million people are facing high levels of acute food insecurity. And the report underlines how this is a growing phenomenon, meaning for the past 5 years, there has been a recorded increase of people need food assistance. So what about infant and child feeding? How is infant and child feeding scoring among the various services of support that we provide globally? The governments and agencies like FHI 360 or others are supposed to provide and support as part of our emergency responses. Well, unfortunately, I personally consider it one of the most neglected area of support that where we invest during our emergency preparedness and response. And what we see and what we have documented, what many of you have helped document, again, I see a lot of colleagues that are certainly very much expert in the area and help document is always, we see how women perceive to be affected by the emergency, how they perceive the stress that they undergo during emergency as affecting their capacity or their ability to provide, for example, to breastfeed or to provide the recommended infant feeding practices. In general, what we see as practitioners is that there is a general lack of investment from the donors agencies, from the governments itself that are responding maybe directly to the emergency in cases where governments are able to, they're able to cope and respond with their own resources. There is really a lack of investment and attention to infant and young child feeding. So most of the time are small or local initiatives that highlights the importance and the needs. We also have documented, unfortunately, years after years, emergency after emergency, and again, Ukraine or Gaza currently, or Turkey, no, the earthquake in Syria and Turkey recently, once again reminded of the widespread donations, no, of infant formula and other commercial products. And again, documentation of the various recent emergencies. We don't need to go too far in the history to see how even companies are exploiting the emergency conditions to market their products, and including during COVID-19 pandemic, something that Carleen, no, has expounded a bit more earlier. So what are we supposed to do? What can we do? And when I say we, I mean, of course, the people around this call, but I mean governments, agencies, and international organizations. Well, you know, in terms of guidance and in terms of protocols, we have, I would say, an extensive set of clear guidance and protocols that can guide, should guide us in what to do and how to do during an emergency in relation to supporting, protecting and supporting infant and child feeding practices. We have also very recent member states agreements on the need, you know, to invest more and to ensure that our preparedness plans, that there are preparedness plans that includes infant and child feeding, that there are capacity building programs, that there is a coordination mechanism. So again, from a policy framework, from a guidance framework, we do have some of the essential tools, no? And these tools are an expression of the collective will, no, to do the right thing and to do it in the right way. So, and I am highlighting one in particular, the infant and child feeding emergency operational guidance. No, the most recent iteration was 2017, that was endorsed by the World Health Assembly as well. But how are we faring, no, from globally, from a government point of view? As you can see, not very recent, but still very valuable report from WHO on the status of implementation of the various policies, nutrition-related policies. You can see that really the infant feeding in emergency aspects, including the International Code of Marketing, are among the least implemented at the government level, no, at the national levels. And you can see that there is really a small amount of countries, no, that are that have, sorry, some explicit protocols related to infant feeding in emergencies. At the same time, and this is a more recent work that was led by Save the Children, the support of the Infant Feeding in Emergency Core Group, a 10 years progress report, no, looking at the 10 years of implementation of the operational guidance for infant and young child feeding, was conducted, a first of its kind, no, to review really how globally, across contexts, these guidances, these protocols were being actually translated into programs, policies, and national frameworks. What were the main findings of this review? Well, unfortunately, well, let me start from the positive. Since some progress has been made, unfortunately, maybe slow, but progress that still highlighted the lack of global coordination and a sustained advocacy to the member states, to the governments, on the importance of infant and child feeding in emergency and the importance to invest in that program, in that aspect of the emergency response. The data that were used, and maybe that's also important to highlight, there are very few limited data being captured by governments, being available, that helps understand the progress made. No? But the few sparse available information, and we are very thankful, for example, to the World Breastfeeding Trends Initiative, as well as the UNICEF data, the data that are being collected by the various offices. But still the limited data available does suggest that there are significant gaps, globally on the interventions that governments and international agencies or national agencies are putting forward to protect and support IYCF in emergencies. At the same time, the report highlighted the lack of governance and accountability mechanisms at all levels. And as I said earlier, there are serious gaps in really understanding where we are in fulfilling the guidance and the commitments that member states have made in the various World Health Assembly resolutions. So the lack of data is certainly an issue that has yet to be addressed. And the same report that I suggest for anyone that is interested to look at, there is also a brief version of the report, does really look into the critical need of increasing investments that can galvanize eventually the protection of infant and young child feeding practices also during an emergency. But what does this mean in an actual scenario? And I wanted to share, so what are all of these gaps and what are all of these issues that I presented a bit broadly means in an actual scenario for the women that are actually and their children affected by an emergency. And I'm looking at a case from Ukraine. It's a paper that we are publishing, and again, some of the colleagues on this call are co-authoring this paper. It's a qualitative assessment that we conducted in late 2022, and the paper is actually in press. So, and this is a quote from one of the mothers that in Ukraine that was obviously affected by the war, current conflict, a conflict that started February 2022, And I think the quote itself already tells you the story of this woman, as well as many other women that are exposed to this conflict. But before giving you the paper, I just wanted to some highlights from the paper. I just wanted also to highlight that we keep learning, and the paper does refer to some of these lessons learned exercises that we tend to facilitate. There was a lessons learned exercise after the 2015 conflict, and there was also a lessons learned exercise that was led recently by the Global Nutrition Cluster that really are meant to help agencies like mine and others to say, okay, now we learn, let's prevent it, right? Let's prevent it again to happen. Let's ensure that we have the resources. Let's ensure we have the capacity. But as you can see, and these are just some of the common aspects that both lessons learned exercises highlight, we don't always learn, right? Unfortunately, and so we need to find a way really to put these learnings into practice. But the learnings are basically what I just illustrated earlier, right? That once again, both in 2015 and the current conflict, violations of the code, no clear guidance or no capacity in the provision of infant formula for those infants that may require it. Again, women that were interviewed, women that were engaged, raising their concern about their ability to produce enough breast milk, hence they shifted to infant formula. Once again, in both decades, the 2015 and 2022 conflicts, donors not prioritizing nutrition as a whole, but in particular, infant and young child feeding support. So again, this lack of investments, lack of prioritization. Let me also say lack of recognition of the importance of protecting women and their infants in their infant feeding practices, right? So being told that, no, this is not something we want to fund, this is not something we need to fund. It has not been then a lessons learned. basically, because we keep receiving the same answer. So what is that we are not doing right in communicating to our donors, for example? Let me go specifically on this exercise, on this assessment that is being published, will be published very soon. This is a bit of the background. I'm a bit concerned of the time. I want to highlight more the quotes from the various moms, and these are, as I said, this is a qualitative assessment of the women affected by the conflict. Well, pre-conflict, many women, and this mother in particular, had only one dream. No? She wanted to breastfeed because she knew how important it was, and this is what the quote is highlighting. No, in a pre-conflict plan, no, in terms of how she was planning, how she wanted to feed her baby. But then, obviously, unfortunately, when the conflict started, the situation drastically, as you can see. And this is again, it's the recurrent issue that we keep documenting, not just in Ukraine, but we have documented in many other contexts. But women admitting that, again, yes, the war is impacting us, and their fears, their concerns and worries that unfortunately are not being answered by any form of support. No? And in fact, when we ask them how they were affected, well, I reiterate the fact that they didn't feel, they didn't experience support. So look at this mom when she said, and these were the very few months after the start of the conflict, when a mother was saying pharmacies were closed, there was no humanitarian aid, and basically she had to resort to an old woman in her village, somewhere in Ukraine, to use to go to a cow and to get the cow's milk for her baby. No? Or another woman, where she said, with the hostilities getting closer, bombing, shelling, obviously her mental health got affected. She was extremely stressed, nervous, and she felt that her milk supply was dropping. No? So you can see that this is really where, well, the rubber touches the ground in relation. What does it mean when infant prenatal feeding is not part of the response, or where women don't feel or don't see or don't have access to the necessary support, and there is no investment to provide that support. And in fact, we validated it, asking clearly what type of support have they ever received at that time, no? At the time of this assessment. And again, the finding of this small study confirmed all the previous learnings, all the previous findings. No, infant formula donations were the only real type of support being provided, with obviously the role of the family in for those that still had a family in feeding and caring for their child. And what was really distressing, once again, is how humanitarian aid was pushing for infant formula, and even when women didn't feel they needed it or even refused, they were, let me say, even forced, no, to receive it, to take it. But this was the most important part for me, or equally important part, when we ask women, what do you need? What can we do? No, hopefully it's not too late to support you in your infant feeding needs. And there were great ideas, there were great thoughts, great recommendations that we have been disseminating across partners. Like this mom were saying, it will be great if we do have a consultant, a lactation consultant, a lactation counselor available at the maternity hospital, so that we can, you know, learn the right positioning for breastfeeding, right? So there were many of these women that we have engaged, we have interviewed, we have discussed with, that were looking forward some form of breastfeeding support, some form of information on how to feed their children. Also in the most distressing situation, like in the shelters, no, when they are going because of the bombardments that were and are happening, unfortunately, still consistently in many areas of Ukraine. No? So the questions, and I put them as a questions because again, and this is all is personal view again, honestly, is we keep saying we are learning something, and I don't think we are learning anything yet, unless, for me, learning means I learn and I'm implementing. I learn and I'm trying to change things based on what I learned. So maybe this is the question for all of us, and I would love to hear your opinion if time allows, but what can we really do? No, what should we really do so that governments, our governments, the donors' governments, and our governments, because there are also countries where emergency are unfortunately part of our life. No, Italy is experiencing many earthquakes here and then, or other type of emergencies. To really invest, regardless of the level of malnutrition, regardless of the level of stunting and wasting. That's the language we want to use, right? What can we do so that IYCF, infant and young child feeding, is a recognized priority because there are women and children that needs that type of support? How can we ensure that this is captured in national policy protocols and budgets? Because yes, we are seeing an increased number of documents, let me call it that way, that reflect somehow infant and young child feeding and emergencies. But the money don't follow. Let's use the term that was being used earlier, right? And again, how do we increase our capacity across the board, no? To do something more meaningful for the women and the infants that are affected by these emergencies and disasters. And again, if you go back to the figures I gave you earlier, basically all women and infants, regardless of context, are affected or will be affected by any form of emergency. And I think this is the last. Thank you.
Wow, thank you so much, Alex. Really appreciate that global perspective on infants, infant and young child feeding in emergencies. It's becoming more and more relevant, isn't it, as the rate of natural disasters and human-created conflict increasing around the globe, and we're seeing the devastating impact that that's having on the nutrition of infants and young children and the mortality as well. And it's so frustrating when there's already all this, evidence-based, well-researched, well-created guidance already in existence. So super frustrating. And I think you really touched on a point there that's already started a little conversation in the chat about the interference of formula manufacturers who like to see emergencies as an opportunity for marketing and for increasing their sales and distribution of their products. And we have a question for you. Carleen has touched on it in the chat, and Libby has also asked, as you may be aware, Australia recently reviewed its measures to implement the WHO Code. And did a review of the MAFE agreement, which is Australia's watered down, weak, ineffective version. And the review report recommended guidance for charities to distribute donations of formula in disaster situations. Now, this was pretty much snuck into the report by industry because throughout the consultation period last year, no one was asked about this, and it's just appeared in the report. Have you seen this trend happening in other countries around the globe, Alex?
Yes, and in both formally or informally, this is what many times governments use as a justification to let me close, to close their eyes also on their own existing regulation. So we have many governments that have regulation prohibiting donations, right? But then when an emergency strikes, they say, well, but this is an emergency. We need to be more lenient. We need to be more flexible, more understanding. So this is what we need to, so it's not about, it's even more serious because they eventually goes against their own regulation, goes against their own direction. It's not that there is a loophole in the guidance, in their regulation that doesn't, is silent on this, right? And so people may take position. So the issue we are seeing is focus on ensuring few things, ensuring that, yes, those that needs it receive the product. But let's have a protocol in place. Let's have the safeguards in place. Let's have the training in place. Let's have the investments in place so that our health workers, health professionals, social workers will do it in the right way, right? Let's not focus on distributing formula. Let's focus on how to ensure that those that needs it, and so identify those that needs it, have a criteria for that. So I think that's what we need to, I would, feedback to the government saying, I'm not fighting the availability, having the formula available. I want to make sure it's available in a way that does not create harm, right, to the feeding practices, to breastfeeding, etc., etc., and is done according to existing standards and protocols. So I would take control, and I will close the issue there in a way. But yeah, so I think I answered more than what you asked. But yeah, we know that that's always the entry point. Over.
Sorry, Alex. Are there model policies on charitable donations for nations?
I haven't seen a specific policy on this. I know some countries like the Philippines do have a specific policy on food donations, and then there is something sub-specific to BMS. But I haven't seen many of them ad hoc or standalone, right? But maybe it's also worth doing a quick analysis of what is out there. But we do see it integrated several times in existing national regulations related to the code or not only the code. Or many times there is a lot of silence, meaning many measures do not speak about it, and that's where we have problems because we deal with them as an ad hoc and it takes longer to discuss and it takes shorter for them to distribute. So while we are still discussing what to do with it, they keep flooding the context. Yeah, over.
Yeah, I think they've seen it as an opportunity to respond to the rising cost of living in numerous, particularly high-income countries, and the rising rate of disasters, and advocates talking about, use of formula not being a food secure approach to nutrition. So very opportune of them, but something that we all need to respond to, particularly here in Australia, very quickly. Thank you, Alex. I have a couple of questions here for Jenny. Actually, I think you've answered that one, haven't you, in the chat, Jenny, from Monica? So
I think I have.
Yeah, great. Thank you for that. I might move on to a question for Monica from Libby. Do gender budgets also count the value of women's unpaid work to civil society, so outside the household, like volunteers to NGOs that support women and in the democracy?
Yeah, very quickly, the work of gender responsive budget would include that. There's some really interesting work recently about that costing or estimating the contribution of voluntary work in the Australian economy. I think they estimate it to be 50% of GDP. But that doesn't mean that governments take account of that. And, we all sort of know how, governments put out policies like, sports activities for children, and they're all sort of based on the assumption that parents need to do a lot of the work, background work. And it's one of these tricky situations because it is good. It's good to get kids in sports. The issue is that the invisible work is not accounted for. We don't have a lot of visibility on all the work that is put out, and it's important to bring more light into that. Yeah, I'll leave it to that.
Thank you, Monica. And Jenny, there was a question for you in the Q&A box, actually, from Jen Hocking. The problem with Australian midwifery continuity of care models has been that they have served women who are low risk and have high levels of social capital, which is an enactment of the inverse care law. How do we increase access to these models of care for all women in Australia?
It's a good question, Jen, and I think Jen Hocking is in Victoria. We think of you as the laggards, I have to say. So a couple of points, and one of them I think is interesting to this audience. I was snooping about a project initiated by Logan Together, which was a collective impact project in the Logan area in southeast Queensland, which is a socially deprived area. And just last week, I was checking that out for other reasons, and I did a LinkedIn request to the chair of the board of Logan Together at this point in time. I've met her before, but a while ago. So I sent a little message, and she wrote back to me, and it was really heartwarming to see. So this is a midwifery continuity care program set up in community hubs in a socially deprived area in southeast Queensland. There are hubs that specifically based in existing community services for Murray and Pacific Islanders, Aboriginal and Torres Strait Islanders, newly arrived migrants and refugees, and young women under the 18 years of age. And she said that the model is so successful that it way exceeded their expectations, and that they now looked at this being the default mechanism, the default program for antenatal care. So I thought that was really encouraging, and I was really pleased to hear that update. But she's right. But I think it is changing. Like Wajang Bajajams is a service set up at the Gold Coast University Hospital that is the intent is that it is First Nations midwives providing to First Nations women or babies carrying a First Nations baby. That's up and going. There's other programs throughout the state. So I guess I would say that most models in Australia, well, most models in Queensland are all risk, and some of them particularly focused on women at high social risk. But if you looked at the paper that I presented today, I think the one that I just made alluded to, there are still significant socioeconomic differences across the board, and there's much less access to women in poor communities broadly, but particularly rural communities. So yeah, we have a lot of work to do. I think you've got to stop thinking of midwifery continuity of care as only for low-risk women. And one of my criticisms here in the UK, and I'm quite critical, would be that they talk about midwife-led care and obstetric-led care, both inappropriate titles in my view. And what they've effectively done is moved everybody out of midwife-led care and into obstetric care. Obstetric-led care, and the midwife's really hard to see her advocacy in that at all. So I don't know if that answers it fully, but yes, the models should be set up for high risk, all risk, but I would say particularly for women at high social risk.
Lovely. Thanks so much for that extra detail, Jenny. Much appreciated. Alison, I've seen your question for Charles, and I'll pass that on to him and hopefully get an answer back to you. I am going to finish that discussion there. Thank you very much, everyone, for your really valuable questions and for participating today. I am going to hand over to Professor Miranda Stewart from the University of Melbourne and the Australian National University for her closing remarks. Thanks so much, Miranda.
Thank you. Can you hear me all right? I'm very conscious of the time, and it's been a really amazing set of really expert presenters, really knowledgeable, as I think has also come through in the chat and all the participation of audience members in the chat. I was going to say I'm speaking from the lands of the Wurundjeri peoples of the Kulin Nation in Melbourne, but I'm actually in Canberra today. So I'd like to acknowledge traditional owners here very briefly. So look, I really don't want to make any kind of long remark. I guess one of the things that's come through, you might think, why have someone who does taxes and budgets do the closing remarks? I think what this whole seminar has shown is the really direct connection between governmental policy, funding, cost, and then real human outcomes, right? Outcomes for women and their babies. And the science is already there, we know, for maternal child care, for infant, for the diet, as Colleen said, for breastfeeding. And we can see through this seminar really a large amount of science available showing the value of these kinds of care through our institutional structures, right? Through the hospitals, through government policy, through emergency policies. So we have a lot of evidence that those things actually work, that they actually do genuinely even reduce cost, which would enable us, of course, to scale up and make sure that everyone in the society, all mothers and children, get access to the care that they need. Just to highlight a couple of things, and I certainly can't highlight everything. It was wonderful to have Emma Hurst do her opening, and as she indicated, as came through in her remarks about the inquiry about birth trauma, many of the issues are financial. They're about government and social funding, the allocation of funding, the allocation of pay, and the recognition of the cost of that, and the interaction between human well-being and animal well-being, which we can see so strongly in the baby formula industry. I think the presentation of Charles and then Monica is showing the link between the federal governmental structures at the federal level and the state level and the way that we do hospital funding. We have some level of transparency, some recognition of maternity services and care, but we do not have full transparency. It's really quite opaque. We really cannot get that traced through, what you could call trace through the budget to determine impact and proper use of funds. And we also heard in some of the other presentations that the kind of calculation of funding, I think this might have been in Andini's presentation, that the allocation of funding sort of depended on babies staying in or going back to hospital because they needed more care, so hospitals get more money, whereas if babies leave the hospital fully breastfed and mother and baby healthy, the hospital gets less care. So we have these less funding. We have these perverse incentives built into the system about proper care of people in general. One of the challenges raised by Monica, of course, how do we trace through gender budgeting through the governmental system? And I think in our federation, something we haven't really worked out how to do is to connect the Commonwealth federal budget and gender budgeting there into the state gender budgeting processes where we actually have service delivery, midwifery services, and so on. And so we need a way to make that fully transparent and be able to trace the financial impact there. I was very struck, of course, by Jenny's presentations about the much better health outcomes and cost savings. And I think as well in Alessandro's presentation about emergencies, what we see again is that somehow the commodity, which is the infant formula, is highly visible in an emergency. It can be packaged, it can be delivered, and the care and work and time of mothers breastfeeding infants becomes invisible. So we circle back to Monica's point about the unpaid care economy and the invisible care. And so thank you very much for holding the seminar. Congratulations to Julie and to Naomi and to all the speakers for your presentations. I think it's all being recorded, so many people will be able to view the seminar again. And this project just keeps on giving, in my view, keeps on producing better and better work and maintaining the networks, keeping up the fight. So congratulations to everyone and have a good evening. Thank you.
Thank you so very, very much, Miranda. Couldn't have wrapped it up better myself. That's an incredible job that you've done there to summarise all of those speakers. Thank you so much. And I see Julie there saying, I'm blown away by all our wonderful presenters and speakers tonight and the engagement of all in our discussions. Thanks so much. Let's go forth and change. Here to that. And it's very late, so we will let you all go. Thank you so very much for joining us, and stay tuned for the next instalment. This has been recorded, so that will be sent out to everyone. And thank you very much.
Thank you. It's been fantastic.